there's some recent research that said that it estimated that if we could just bring the outcomes for African American, Hispanics, and Asians up to the level of whites, then we could save $230 billion over a period of a year, over a period of 4 years, excuse me. And then, if we were to consider the indirect costs in terms of missed productivity, as well as the inequities of what they cost in terms of people dying early, then that savings would go up to $1.3 trillion. And if we look at the plans that are on the table right now, if one is going to cost them $707 billion and the other is $1.2 trillion, then we're talking about if we would just remove the inequities in care, and if we would insure people so that everyone would have somewhat of the same outcomes, then we're talking about the kind of savings in 4 years that these plans that are on the table cost in their entirety. So I think that that's a way that we need to start thinking about reducing the inequities that are in the system itself. And I want to get back to what Paris said, that these are moral issues. I mean, and I was thinking today when I was thinking about coming up here, you know, my parents taught me that some things are just right. You know, some things are just the right thing to do. So being a preacher and being a person of faith, and Christianity is the only religion that has a golden rule. So I think that if we have an opportunity to do something that's right, something that's just, where our fellow human beings are concerned, we ought to do it. As you would that others would do unto you, do ye also unto them.
I'm going to pose this question at Steve Roberts, although others can answer it. Will new health care legislation put small business owners in jail if they cannot afford mandated premiums? And I guess that's referring to the employer mandates.
I don't know.
And maybe generally you just talk about employer mandates.
Yeah, I don't mean to be flippant in my answer. I just suspect that nothing is going to pass that puts employers in jail. That's something in my gut tells me that's the case. But I will, this perhaps is an opportunity to say that I think the employer community is pretty united in its belief that the private insurance market needs to be preserved, and that the private insurance market does not deserve the kind of whipping that it is taking in the minds of some. You know, when we go back to the notion that 180 million Americans get their insurance through their employer, through a private insurer, that's a pretty astounding number. And the numbers of employees who are satisfied with the insurance benefit they have is very, very high. So while we are careful to say that we do support much of what is on the table, we have much common ground here, I'll just take this opportunity to say that certainly from our point of view, preserving and strengthening the private insurance market is a law.
Thank you, Steve. Here's a question that I guess everybody can sort of answer, so just raise your hand if you want to take this on. What's the panel's viewpoint of inclusion of funding for prevention efforts and of premium differentials for smoking, obesity, and those types of things? Whenever I hear that kind of phrase, I turn to Fred. So maybe Fred can start off and talk about preventative care and programs.
Well, I'll take it first out of it, although I think Louise probably has some great items to add as well. But I support that because clearly one of the true cost drivers is the care of chronic conditions in our healthcare system. That's particularly true in West Virginia, where you see us near the top of the list, or at the top of the list, in so many chronic medical conditions, from whether it's obesity related to diabetes or COPD or high cholesterol, et cetera. I mean, the list goes on and on. And part of the care for this, and I think this is important to note, and Louise made reference to medical home to get much more attention to those type of conditions and to help people manage those conditions much better and to address them early before they become the high-cost items that we see in the system today. But just as important that is, how do we go about changing people's mindsets and their activities and their actions so that some of those things which are truly preventable never occur? I mean, you look at the obesity rate in West Virginia and some of the other states that are similar to us, and how can we get people to change so that those conditions never occur in the first place? That's where the real savings is. You know, and I have to say this to one other item on this, is that we're often compared to other countries in terms of their costs and how their systems are so much better. Well, a lot of that has to do with the conditions of the people themselves and how much better care they take of themselves so that they're never getting those conditions in the first place. And that's where we really need to change the mindset of the country, where we truly get our healthcare costs under control.
Just to follow up on some of those comments, one of the biggest challenges with prevention is that it is currently not funded or underfunded from two angles. One is the education piece to it. So when you have a newly diagnosed diabetic and it takes a significant amount of time to provide that patient with education regarding self-management, there is no reimbursement for it. On the other end of the spectrum, there are preventive services, such as those under that would fall for Medicare, that are not a covered benefit on a routine basis. The House bill, the Senate bill, and the Senate Finance bill all have components within them that would increase funding for routine preventive screenings, as well as educational programs and grants that would help to work more with the education piece for chronic disease.
Thank you, Louise.
I was just going to say that since 1 out of every 5 West Virginians is a Medicare beneficiary, that we think out-of-pocket costs for those preventive care type things, diabetes screenings, cancer screenings, also attribute to the fact why people don't have the screenings and they become chronic conditions. So we'd suggest that perhaps eliminating some of those out-of-pocket costs, or at the very least reducing them, would be an important aspect.
Just one thing to add to that, you know, is you see a lot of that, and you've heard some discussion back and forth on the Medicare Advantage plans that are available as an option to seniors in the Medicare market. And typical of those plans, you would see those preventive benefits covered at 100% up with no out-of-pocket cost to the seniors. And some of the changes that may be made to those plans because of funding cuts to those plans should be something that this audience is concerned with.
Next question, and Perry, I'll throw this at you, and there's probably others who would want to answer this as well. The bills being considered do not provide universal access to care. The essence of any bill should focus on access, not just coverage. Free clinics provide care to over 50,000 West Virginians. If West Virginia Health Right went out of existence, where would the 18,000 uninsured go for services?
That's a difficult question. I assume an awful lot of them would end up at the community health centers to increase funding. But you know, the question of access and insurance. Most people who don't have insurance don't have access. Those who don't have insurance don't have access, with limited exceptions of free clinics and the community health centers. Having insurance, though, provides people with greater access. And so it's not a solution in and of itself, but it is a significant step in the right direction, making sure that people who don't have access would have access in the future.
Thanks, Barry. Anybody want to jump on that at all, Louise?
Just to clarify a little bit, the free clinics there are approximately 10 free clinics throughout the state. They are under a different program in community health centers. And the most unique difference is that they provide free care, whereas community health centers have a fee schedule. Some of the patients who receive care in community health centers do not pay at all based on their income. Others would pay on a sliding scale based on that income. So while some patients in community health centers would be considered free, others would be paying, if they're covered with insurance, would pay the full fee.